that thrombolytic therapy in general has been an evolving field over the last few decades, and I think you're seeing more and more attention toward some of the next generation thrombolytic agents. Alteplase has been around for quite some time and first approved in 1996 for treatment of acute ischemic stroke. And if you look at the other drugs that are available on the market that have been used for myocardial ischemia or in other clinical situations where thrombolytic therapy might be indicated, probably the most advantageous drug when we're thinking about its use now, or probably the most studied right now, is Tenecteplase. So Tenecteplase is a next generation thrombolytic agent, also a recombinant TPA molecule that has a 3 amino acid substitution that allows it to be resistant to certain molecules that might degrade a tissue plasminogen activator. So those are largely the plasminogen activator inhibitors, especially plasminogen activator inhibitor type 1, which is part of the feature of Tenecteplase, is that particular Tenecteplase molecule is resistant to Pi1, whereas Alteplase is not. So I think this leads to the idea that also it's a more potent fibrinolytic agent. It breaks down fibrin more effectively than Alteplase does and might be a more effective agent. It's also a little simpler to administer. So when you're looking at the idea of giving Alteplase, it requires an initial bolus and then an infusion that hangs over an hour. Whereas most of the administration now that people are looking at for the use of Tenecteplase and thrombolytic therapy, in most of the studies now are looking at single bolus administration. So that single bolus obviously simplifies the use of the medication. There's certain information you're going to need up front. So when you look at the use of these novel agents, I think getting drug sooner to patients, and that's more of a systems of care issue and potentially a technology issue and other means besides CT scanning technology to be able to rule out intracranial hemorrhage in patients with stroke symptoms. And if you look at the use of these newer thrombolytic agents, whether it's use of Alteplase or any of the newer thrombolytic agents are being considered, it's this kind of early administrations can be critically important. So when we think about novel approaches to thrombolytics, the first thing we should be looking at novel approaches that get drug to patients faster and are more effective and give the patients the effective early evaluation. And that's the use of things like mobile stroke units, which bring basically the emergency department for stroke to the patient's doorstep. So being able to deliver thrombolytic therapy earlier could reduce disability, improve clinical outcomes, regardless of the thrombolytic agent that used. But coupling this with a better fibrinolytic drug or thrombolytic drug could pay additional dividends. And clinical trials are currently underway looking at subsets of populations to try and see whether these novel thrombolytic agents are better. Right now, I think some of the ideas also stem from the idea of, can we use some of these thrombolytic agents even further out from time last known well? So the idea that we could use a thrombolytic agent after 4.5 hours, what we would call like late window thrombolysis, as most IV TPA is being administered in the first 4.5 hours. If looking at the use of drug after 4.5 hours might occur in specific clinical situations. First of all, the patient has to benefit. So there has to be some mismatch between the amount of infarct that has already taken place, the core area of infarction, and the area of at risk. So there has to be some means of determining whether the patient is a viable candidate for that. And systems and stroke systems have to be put in place in order to screen patients for that. And that's a daunting task when you're talking about a large population of people that have to be screened, when there's probably only a relatively small population that will actually qualify for the late window thrombolysis. In addition, we look at, well, what is beneficial in that patient who may benefit after, let's say, 4.5 hours? Well, you have a subset of people who may have large vessel occlusion that have a big mismatch in many circumstances between the area of infarction and the area at risk. So the most effective therapy that we can find for that population is thrombectomy. removing the clot safely through mechanical means mostly is going to be your most effective way. Restoring blood flow has a huge benefit to patients. The number needed to treat is somewhere between 2 and 3, depending upon the study that you look at, in terms of patients who may have an excellent outcome as a result of being treated, or good or excellent outcome if they get thrombectomy versus not getting thrombectomy. How much additional benefit do we get from use of a novel thrombolytic agent or a drug like Tenecteplase or even Alteplase in an extended window to those patients who have large vessel occlusion is sort of uncertain. Current studies are underway to look at that issue. Studies like the Timeless trial is looking at this population of patients with large vessel occlusion who may benefit from additional administration of Tenecteplase prior to actually the beginning of thrombectomy. Other clinical studies might look at other novel strategies using different agents and similar methodologies. We've already seen some trials of late window thrombolysis and found that these trials suggest that there is some benefit to late window thrombolysis in this subpopulation of patients. So it's less that this doesn't seem like a viable concept, then what's the best agent now to use in that situation? I can see that it might be beneficial to look at a drug like Tenecteplase in this extended time window concept. Yet there are no current clinical trials planned, I believe, in the non-large vessel occlusion population. There has been some thought of using it in a population of patients, but I don't believe there's a current trial ongoing in the United States in this extended time window using Tenecteplase. However, I'm sure that there are trials going on. So in fact, I know that there are trials looking at Tenecteplase in the extended time window. I mentioned in the large vessel occlusion population the Timeless trial, but there are other studies looking at Tenecteplase use in this extended time window, and they have a variety of different criteria, but they're not really enrolling yet enough patients that we can get meaningful information to talk about the benefit in that population.